Welcome back, students. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. In our last session, part 65, we wrapped our heads around home health PPS and PDGM. Today, for part 66, we're shifting gears and unlocking a truly high-stakes puzzle in the world of healthcare finance, inpatient hospital coding. If you've ever wondered how complex clinical documentation translates directly into actual hospital reimbursement, you are in the exact right place. We're going to decode the precise systems that hospitals rely on just to keep their doors open. We're talking about the Inpatient Prospective Payment System, or IPPS, and the diagnosis-related groups, the DRGs, that drive the whole shebang. Every single keystroke from a medical coder can literally mean the difference between a fully funded hospital department and a devastating revenue loss. So let's jump right in and decode this fascinating process together. Okay, so here's our game plan for today's explainer. We're starting off with the inpatient revenue cycle, and then we'll move into decoding the MS-DRG system. After that, we'll explore principal diagnoses and POA indicators, crack the code on ICD-10 PCS, and finally, navigate the world of CDI and denials. Let's kick things off with Section 1, the inpatient revenue cycle. To really grasp why these codes are such a massive deal, we've got to understand exactly where inpatient coding fits into the broader hospital workflow. It isn't just some administrative afterthought, it is the absolute engine of a hospital's financial health. This beautifully captures the domino effects of revenue cycle management. Notice how every single step relies entirely on the accuracy of the one right before it? It all kicks off at patient admission with registration and insurance verification. Next comes care delivery, where every single test, surgery, and nursing note gets documented in the electronic health record. Once discharge happens, the baton is passed to the IPDRG phase, coding and grouping. This is the exact moment where coders assign those make-or-break ICD-10 diagnoses and procedure codes. Only after those codes are grouped into a payment category can claim submission and ultimately payment posting happen. Think about it. If the documentation during care delivery is vague, the coding will be completely off, the claim gets flawed, and boom, payment denied. It's a completely interconnected loop. All right, moving right along to Section 2, decoding the MS-DRG system. Let's look at the core mechanism of hospital payments. We hear the acronym DRG thrown around all the time, right? But let's actually break down what a Medicare Severity Diagnosis-related group is and how it dictates the revenue cycle. So the crucial takeaway here is that Medicare, and honestly most commercial payers too, pay a fixed prospective rate based on the DRG, rather than handing out an itemized bill for every single bandage, blood test, and pill. The DRG system essentially groups hospital cases into about 750 distinct payment categories based on clinical and resource similarity. When a patient is admitted, the hospital pretty much knows what they'll be paid based on that final DRG, regardless of whether the patient stays for 3 days or 5 days. It completely shifts the focus onto having rock-solid clinical documentation to ensure the hospital lands in the correct payment category. Now, this is where it gets really interesting. How does this system account for how sick a patient actually is? Well, once the base DRG is set by the primary reason they're there, the system looks at secondary diagnoses. A CC, which stands for complication and comorbidity, is a secondary diagnosis that adds moderate weight to a DRG because it increases resource use. But an MCC, a major complication and comorbidity, represents a very significant diagnosis, something like acute kidney failure or severe sepsis. That significantly bumps up the resources needed to treat the patient, which in turn drastically increases the reimbursement. To really put this into perspective, let me share a real-world example from our source material. Imagine a patient is admitted for simple pneumonia. The coder properly codes the pneumonia, but, whoops, misses a secondary diagnosis of chronic obstructive pulmonary disease, or COPD, that was buried in the notes. COPD is classified as a CC. By missing that one secondary code, the DRG assignment dropped from simple pneumonia with CC down to simple pneumonia without CC. That tiny, seemingly insignificant documentation gap caused the expected reimbursement to plummet by exactly $2,300, just one missed code on one single patient. Multiply that by thousands of admissions a year, and you can absolutely see why this is a high-stakes puzzle. Let's move to Section 3. Principal diagnoses, and POA. We're going to see how this builds into the specific rules coders use to select the right diagnosis. It's not just about listing everything wrong with the patient. There's a strict hierarchy and timing element that absolutely must be followed. This right here is a critical distinction that coders and clinical teams simply must master. The primary reason for admission is really just the chief complaint. It's the symptom the patient walked in the door with, like severe chest pain. But the principal diagnosis, that is the condition established after study to be chiefly responsible for occasioning the admission. So if a patient comes in clutching their chest with severe pain, but after an EKG and some labs, the diagnosis is confirmed as an acute myocardial infarction, a heart attack, the principal diagnosis is the acute MI. The MSDRG is determined by that principal diagnosis, not the initial symptom. If you code the chest pain as the principal, your DRG is going to be completely incorrect and drastically underpaid. And we get even more granular. The coder has to flag every single condition to prove exactly when it happened using POA, or present on admission indicators. Y means yes, it was present when the patient arrived. N means no, it wasn't present. It developed during the stay. U stands for insufficient documentation, and W means the provider is clinically unable to determine when it started. Guys, this isn't just administrative red tape. These flags are the dividing line between a pre-existing comorbidity and a complication that the hospital might actually be financially responsible for. And this is exactly why those POA flags are so incredibly vital. Let's say a patient is admitted and 2 days later they develop a deep vein thrombosis, a DVT. A DVT is usually a major complication, an MCC, which would normally boost the DRG payment. However, because it developed after admission, it gets an N flag. Under Medicare rules, this is considered a hospital-acquired condition, or HAC. Conditions with an N flag literally cannot be used to increase the DRG payment. Instead of getting paid more for treating the DVT, the hospital might actually face a bundle payment penalty. The timing recorded in the clinical documentation literally dictates the financial outcome. Jumping into Section 4, cracking ICD-10 PCS codes. Now we get to the really fun part. While diagnoses explain why the patient is there, procedure codes explain what the hospital did to treat them. And the inpatient procedure coding system, ICD-10 PCS, is built exactly like a combination lock. Take a look at this. It maps out how every single PCS code is constructed using a strict 7-character access. You don't just look up a word, you actually build the code. Let's take a coronary artery bypass graft, a CAPG. Character 1 is the section, medical and surgical, so that's a 0. Character 2 is the body system, heart and great vessels, a 2. Character 3 is the root operation, the main objective of the procedure, which is bypass, a 1. Character 4 is the exact body part, coronary artery, 1 site, 0. Character 5 is the approach, open, 0 again. Character 6 specifies the device used, like an autologous tissue substitute, which could be a 9 or a J depending on the exact vessel. And finally, Character 7 is a qualifier for any extra detail, like a Z for none. Literally every single letter and number represents a highly specific clinical detail that absolutely must be found in the operative report. So where do coders find all these details? Well, they look at the inpatient face sheet, among other documents. Looking at an actual face sheet here, notice this highlighted area? This is where the principal procedure is officially recorded. The principal procedure is typically the one performed for therapeutic rather than diagnostic purposes, and it's usually the major surgery that drives the surgical DRG. Meaning, if a patient had an exploratory diagnostic procedure and then a major therapeutic bypass, the bypass goes right here in this field, and it completely dictates the payment category. And right below it, on that very same face sheet, is the field for secondary procedures. This is where those diagnostic procedures, things like tissue biopsies, colonoscopies, or cardiac catheterizations are logged. Now, even though they might not drive the primary DRG, they complete the clinical picture and are totally essential for accurate data collection and quality reporting. It is important to note, though, that routine ancillary tests, your basic x-rays or standard lab work, aren't assigned PCS codes here. Only significant diagnostic and therapeutic procedures make the cut. Moving on to our final segment, Section 5, Navigating CDI and Denials. So what happens when the physician's documentation just isn't clear enough to build these complex codes? That is where Clinical Documentation Improvement, or CDI, teams swoop in as the real heroes of the revenue cycle. They act as the vital bridge between clinical care and medical coding. They do concurrent reviews, meaning they're reviewing the chart while the patient is literally still sitting in the hospital. If a doctor scribbles down a vague symptom instead of a definitive diagnosis, the CDI specialist will issue a query to the clinician asking for clarification. And look, this isn't about gaming the system at all. As our source material points out, it's ethical optimization. It's simply ensuring the hospital's records reflect the true severity of the patient's illness so the hospital is compensated fairly for the intense, real-world care they are providing.
But hey, even with stellar CDI, payers are sometimes going to push back. They might deny a claim, questioning the medical necessity or the DRG assignment. When that pushback happens, the hospital's denial management team steps up to the plate. They have to compile undeniable clinical evidence from operative notes, lab results, and discharge summaries. They track those POA indicators to prove conditions weren't hospital-acquired, and they draft highly structured, data-driven appeal letters. Navigating these advanced payer negotiations is really the ultimate defense to protect a hospital's revenue integrity.
I'll leave you with this final thought. In the complex, high-stakes puzzle of healthcare finance, from the very moment a patient is admitted to the final denial appeal, every single keystroke matters. Documentation drives coding drives the DRG, and the DRG drives the revenue that keeps the hospital lights on. So whether you are a clinician, a coder, or an administrator, you've got to ask yourself, are you making sure your keystrokes count? Okay, that wraps up this explainer for Part 66. Next time in Part 67, we'll be teasing apart the ambulatory surgical center payment system and outpatient DRG crosswalks, so you definitely won't want to miss that. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. See you next time!